All right, everyone, we're going to get started. Hello, and thank you for joining the League of Women Voters Northern Lower Michigan Public Forum tonight. A few reminders as we start. Everyone is on mute, and that's intentional, so keep your fingers off of the unmute button until the very end. It's also best to click on speaker view instead of gallery view so that we can focus on each panelist as they present. And as usual, this presentation will be recorded and made available on our YouTube channel, and the link is always posted on our webpage. We're asking members to stay after the public program portion ends for a brief member meeting. And I'm Robin Jordan, I'm the local league president. And for those of you unfamiliar with the League of Women Voters, we are a nonpartisan political organization that encourages informed participation in government, works to increase understanding of major public policy issues, and influences public policy through education and advocacy. We do not support any candidate or political party. We do have public policy positions that inform our education and advocacy work, and we offer public forums on topics of community interest. We have a robust and active healthcare committee and are pleased to offer this public forum on the complexity of prescription drug pricing. Our moderator this evening is Eileen Mikas, who co-chairs the healthcare committee with Pat Freilich, and I'm going to turn it over to Eileen.
Thank you, Robin. Thank you for joining us, and please put any of your questions in the chat box. We'll have our question and answer session after our two speakers. It's my pleasure to introduce our speakers for this evening. First is Greg Wellman. He's the PhD registered pharmacist and professor of pharmacy at Ferris State University. Ferris State is where they've had a 4-year program in pharmacy since 1936, and currently they're the largest college of pharmacy in Michigan. They graduate between 100 and 120 students each year that go into pharmacy. Dr. Wellman joined Ferris State University in the year 2000 after 15 years of hospital experience in the pharmacy area, hospital pharmacy. Our second speaker tonight is Tom Burns. Tom is a recent graduate of Ferris State College of Pharmacy. He's worked in community pharmacy settings for the past 10 years, and currently he's in the community pharmacy residency program, working in multiple pharmacy practice types, including grocery pharmacies and outpatient doctor's offices. And Tom has told us that his passion is advancing the role of the community pharmacist, which I'm sure this program, no doubt, will serve to help him reach that goal. So now I'm pleased to turn it over to Greg Wellman to start our program.
Thank you, Eileen and Robin. Let me just switch into screen share here. Okay, can you see the slides?
Yes, we can.
Okay, great. Well, thank you for the opportunity to talk this evening about the very complex question of prescription drug pricing, and also kind of roles and responsibilities of pharmacists to help with managing the complexity of prescription drugs. Some of the questions that we're going to try to answer this evening, I've kind of tried to list here. How are drugs approved in the United States? Why are drug prices high and continue to rise in price? What's the impact of this new legislation, the Inflation Reduction Act, on drug pricing, potentially including insulin? And then Tom's going to talk about pharmacy discount cards, roles of the pharmacy benefit manager, and really how your pharmacist can help manage your prescription drug costs and your drug therapy. As Eileen said, if you have questions, please feel free to drop them into the chat, and we will be reserving time at the end to cover those questions. I'll be occasionally looking at my timer here because I'm trying to make sure I move it along and get us on track to some question and answers. So the first thing is really, how do drugs get to the market in the United States? And it's a multi-phase process. Generally, people will say it's it's really a 4-phase process, but it's a little bit more than that because before you even get to phase 1 testing, you really have what we call preclinical work, which is done, which might be animal testing. It might be work that's being done in test tubes, so to speak, or really done in tissue cultures of some type. And then once you kind of get to the point where you can begin to put in humans, and you would really be in phase 1 testing. Phase 1 testing is really very limited numbers of healthy subjects, usually 20 to 80 subjects. And really what they're trying to do at that point is just get some understanding of the safety and how the body handles the drug itself. How does the body break it down or metabolize it and get rid of it or excrete it? And it's really when you get to phase 2 testing that you're really working with testing in human beings that have the disease or patients. And those phase 2 trials are generally going to be in the hundreds of patients, maybe 100 to 300, 400, 500. And really at that point, trying to understand what's the best dosing to use, get some understanding of, is the drug moving the needle on the disease state or its effectiveness, and then begin to accumulate information on common side effects. And usually it's going to be about 3 years before you're going to get to the beginning of phase 2 testing, another 3 years to complete phase 2 testing and get you to phase 3 testing. And phase 3 testing is really where we call the clinical studies are done. And again, we're talking maybe 300 to 3,000, 4,000 patients in size. Sometimes there will be 2 clinical trials that'll be done and required by the FDA, sometimes only 1. And then at this point, we're really, again, looking more specifically at the patients who have the disease. And we're looking to determine, is the needle being moved on the disease state, or are we seeing effectiveness? Understanding more about safety. So safety is being gathered really throughout this process of phase 1, phase 2, and phase 3. And then again, continuing to accumulate information on side effects. So really it's at the end of phase 3 that and really the FDA is monitoring all through this process. So even as these studies are being developed, the FDA, the drug company, is typically working with the FDA on the protocols and the kind of do's and don'ts that are going to happen. So then you get submission after phase 3, which is about a 4-year phase, to the FDA for review and approval. And then it'll be reviewed at the FDA. A committee will make recommendations to the full body of the FDA, and then the FDA makes a determination regarding approval. But that's not really the end, because then we have what's called phase 4 testing, where additional information may be being gathered by the FDA in addition to the drug company. We call this post-marketing surveillance, where we're really trying to understand the long-term effects of the drug treatment. Are there some things that we didn't see in the clinical trials because of the limited number of patients, and also trying to garner information on rare side effects that can occur, which I'll come back to in the next slide. I want to note that there are some drugs that can be accelerated or fast-tracked out of phase 2 to approval. And so, and it really depends on a number of different criteria in terms of the disease, how severe the disease is, how many drugs are available currently to treat that disease state. So Leqembi, which is the drug you're hearing all about in the news these days for Alzheimer's, that was actually an accelerated approval by the FDA out of phase 2. And there is data on phase 3, which I think the phase 3 trial is completed. And that information is currently under review and being completed, and will get to full review by the FDA. So that's an example of that kind of accelerated approval, where they'll jump a drug to market after phase 2. A couple of things I want to note about that and point out is that clinical drug trials range between 300 and 3,000 subjects. And I think that's an important thing to remember, and that these drugs are going to be approved and used in millions of patients. And that's generally the reason why we see, I'll oftentimes get the question about a rare side effect that occurs and why didn't they see that during clinical drug trials. And it's typically because if you have 3,000 subjects in a trial, and you have a side effect that occurs even in 1,000 people, let alone 10,000 or 1 in 100,000 people, then it's not going to be picked up in a clinical drug trial. And those side effects that are rare are typically more potent and more dangerous. And so that's oftentimes where post-marketing surveillance comes into play. So that leads us to the next question, which has to do with pharmaceutical pricing. Why do prescription drugs cost so much? And we're generally told through politicians and drug companies, and even many economists, that the reason is because of how much it costs to bring a new drug to market. And the number that kind of gets said over and over again currently is $2.6 billion to bring a drug to market. And the one thing I want to point out about that number is that it's not actually a truthful number, in the sense that that is not how much a drug company pays out of pocket. Okay. The out-of-pocket expenses of the drug company are really a little bit less than half of that, which would be around $1.4 billion, not accounting for their tax breaks, which probably takes it down another couple $100 million. So really, and the reason that that number is quoted as higher is I don't really, time isn't going to allow me to really go into what they call cost of capital adjustments that are made, but it's really inflation, business related investment expense that goes into that number. But the actual out-of-pocket expense is probably more around $1 billion to bring a new drug to market. And also, because there are no price controls in the United States for prescription drugs, we actually pay approximately twice what is paid for the same drug in other developed countries around the world. So you can look at Europe, you can look at Australia, you can look at other developed countries. In the United States, we roughly pay twice the cost of a drug, accounting for currency exchange. So why is that occurring? And I like to think of it this way: in free and open markets, for free and open markets to operate like we have in the United States, where we don't have price controls on drugs, there's 5 things that have to happen. And these are the fundamental economic rules of free markets. And I like to think of these as the natural predators to price gouging. And if you think about the things that you buy every single day on Amazon or at the grocery store or at whatever store you might shop at, you can see that these rules need to apply. First of all, the consumer needs to be able to select from among several different choices. So you go somewhere, you go on Amazon, you have multiple things to choose from, and you can shop to the price and constituents that you want. Well, prescription drugs, the prescription itself tells you what you're going to have, what you're going to be taking. So from the consumer standpoint, that does not occur. There isn't selection. In addition, there must be many buyers and many sellers. And there are certainly many buyers of prescription drugs. And there are kind of many sellers, although there's probably only about 1/3 of the major drug companies that are around today, the big players, as compared to when I started out in pharmacy decades ago. So that's probably fine. In addition to that, the consumer must understand all the aspects of the different products that they would have to choose from. So, for example, if you need treatment for your cholesterol, then you would need to understand the depth and breadth of all the products that could be selected for you. Well, we delegate that responsibility to the physician and the pharmacist. So as a consumer, we don't have access to that information. So in essence, that one's kind of like not in play. And in addition to that, patents keep these products really the diversity or the availability of generics for many, many years before those can come out of the market. In addition to that, sellers cannot create blockades to price negotiation, and that's not true. For example, we'll talk about with respect to Medicare. Medicare, which spends hundreds of billions of dollars on drugs in the United States, was not allowed up until recent legislation to negotiate drug prices. So in essence, we have these blockades that exist. In addition to that, buyers should be able to exit the marketplace. So if you need a new flat screen TV and you go and you look and you want to maybe get a 70-inch television and you look at the prices and you say, I can't afford that, I need to step down to a 50-inch, that I can afford, then you are able to exit that marketplace. They don't lock the doors behind you at Best Buy and say, I'm sorry, you can't leave here unless you buy a 70-inch television set. Well, a person who is very ill, they do not have the ability to exit the marketplace. For all intents and purposes, they need that medication to continue to survive in some cases. So we really break 4 of these 5 rules. And by doing that, we basically eliminate the marketing predators that are going to be out there working for us to reduce price gouging. We can think of this another way. When these predators are taken out of play by these broken rules, we really remove what we call elasticity, or the bending in the prices that can occur. And so what that means is a company can increase the price of the drug, and it's not going to impact the quantity that people are going to consume. And the best example of this that we've all been living recently is gasoline. Gasoline is considered very inelastic. Gasoline could be $10 a gallon tomorrow, and the amount of gasoline that I'm going to buy every day is really going to remain unchanged. It might prevent a vacation I might take, but other than that, I got to buy the same amount. So they can raise that price, and there isn't really much that can be done about it from a consumer standpoint. And measures of like gasoline also apply to prescription drugs as well. So how can this be affected? Well, one of the things recently that could have an impact on this is the Inflation Reduction Act. And the Inflation Reduction Act, which was very recently put into law. Again, as I said, the Center for Medicare and Medicaid Services spends close to $400 billion a year on prescription drugs. In total, in the United States, there's about $400 billion spent on prescription drugs. Some people cite it as high as 600, but if we take out the rebates from drug companies paid back to the buyers, it's probably more about 400 billion. And 120 billion of that is spent under Medicare Part D for those individuals who are on Medicare. Up until this legislation, by law, Medicare was not allowed to negotiate prices. So imagine you owned your own business, or maybe you own your own business and you're making, whatever it is that you're making. Let's say you were not allowed to shop your prices. You were required to pay a particular price from a particular vendor, and they got to charge you whatever they want, and you were not allowed to negotiate vendors against each other. That would be untenable for your business. The Inflation Reduction Act removed this prohibition from law, but because of the heavy lobbying that occurred by the drug companies, there's a lot of caveats that were put on it. And so basically, it's going to take about 7 years to implement. In 2024, I think it is, they will be allowed to negotiate only 10 drugs on Medicare, and then they're allowed to add another 15 the following year and about another 15 the year after that. And there's a lot of rules and regulations about how they can implement that. But nonetheless, this will at least begin to put Medicare in a position where they can pit drug companies against each other in a competitive environment. In addition to that, it will have some impact on changes in Medicare Part D. It removes some of the patient costs, the co-insurance that exists for catastrophic coverage, which is that kind of kickback in of the beneficiary expenses when you hit that kind of top end. It will implement a $2,000 annual cap in 2025, but there will be somewhere around $3,000 to $3,250 between now and 2025. It's going to shift the responsibility for paying discounts back to the drug companies that the government was paying, and it's going to shift that responsibility back to the Part D plans. And that's probably, there's some thought that they may increase the premium, some of the premiums associated with Medicare Part D. They are putting a 6% premium growth limit in place in 2024 through 2029 per year. And it will allow beneficiaries to spread out their out-of-pocket expenses over the year. Now, one thing I want to say about these rules is these apply to the baseline Medicare plan. So Medicare plans can offer better coverage. So some may get better coverage than these, but these become the baseline for all plans. And then in addition to that, with respect to insulin, it will limit the monthly patient payments for insulin products to $35, only applying to Medicare. The original legislation attempted to put it into place for all prescription drug plans, private and public, but that was heavily lobbied against by the Pharmaceutical Manufacturer Association. And so it was limited to Medicare. And there are some things that kick into place in 2026 that allow that price to go under $35, looking at some other kind of, Medicare negotiated prices, et cetera. So it could get less than $35 after 2026. So I'm going to stop there. And with that, I am going to turn it over to Tom.
All right, thanks, Greg. Pull my PowerPoint up here. Attempt to, anyway. All right. Can we see this?
Yep. Yes.
Okay, and you can hear me. Great.
Oh, do you need
Is
to
it in
switch
the-
to the display setting?
Oh, yes.
The
Sorry
very
about
top.
this, guys. Very top.
Click on that and then swap presenter view and slideshow. There we go.
Like that.
Now we're good.
Wonderful. Okay, so I'll be focusing on the second half of the problem here with drug pricing and focusing on the front end of the pharmaceutical process, which is how the medication gets from the manufacturer to the pharmacy and the associated costs with this process. To understand the prices the patient is paying at the pharmacy, you really need to start with how the price is established at the pharmacy. And to do this on the screen, I have on the screen the distribution and reimbursement system for outpatient medications, and I'd like to focus on this diagram in two different chunks. I'll start first with the left-hand side here, which really explains how the physical medication gets from the manufacturer to the pharmacy. And then I'll discuss the right side, which follows more of the insurance premium paper trail and the costs associated with premiums and things like that. So let's start with the focus on the left side, which includes the manufacturer and the wholesaler. Okay, so the manufacturer. This is really the entity that invents and produces the medications. Like Greg was talking about earlier in the presentation, the entities that go through the trials and develop the drugs. They create deals with wholesalers to purchase medications and then package and ship to a wide variety of consumers or customers. So what I mean by this is the wholesalers will buy drugs at a below average cost and then package them and distribute them to many locations so they can really take care of the distribution bottleneck in their process. Brand name medications this is the first issue. This is your first part of the price increase in some of these medications, right? Brand name medications are sold at a wholesale acquisition cost minus a negotiated amount. So regardless of how many units are sold, there is no discount, which is untrue with generic-based prices, which are set by volume-based purchases. So the more that you purchase, the cheaper the medication is for the pharmacy in units. Moving on to the wholesaler here, which stores and ships a wide variety of the products to pharmacies, like I said earlier. Think about this like your warehouse for a grocery store. So it's where the grocery store has all of the products in the back end. Like I was talking about earlier, the average wholesale prices are developed from an estimated average price that pharmacies pay for medications from wholesalers. What I mean by this here is that wholesalers sell to a lot of different pharmacies, right? Depending on the amount of units a single pharmacy buys, it could be more expensive. If you are a large chain, you could buy a lot of that unit and get it much cheaper. So the average wholesale price is created by a third-party entity of the average cost of the drug across the board. Now, insurance companies reimburse pharmacies based on the average wholesale price of the product. So if you are a pharmacy that can purchase 100,000 units, and get that price much cheaper, you're making a little bit more money versus the mom and pop independent pharmacy. They can only purchase 100 units and then is actually losing money because they're paying more than the average cost of that medication. Group purchasing organizations may negotiate prices with wholesalers by purchasing larger amounts of medications. And what this is smaller chains of pharmacies will band together to place orders for the same products at wholesalers to act like a larger entity so they can get these cheaper prices. All right, so now I'll focus on the right-hand side of this table, this graph here, diagram, excuse me, which talks about the third party and the pharmacy benefit manager and their roles in drug pricing. So the third party payer, the health plan, your insurance, they collect insurance premiums and provide insurance coverage to the patient. And they contract with an entity, the pharmacy benefit manager, to secure lower drug costs and develop formularies. Formularies are a list of prescription medications that are designed, and is what these pharmacy benefit managers will do is they will negotiate with the drug manufacturers for lower cost products to put on their formularies. So they will say, we will put your drug on our formulary if you cut the cost down to make it more affordable for the third party payer and then the patient, right? Well, the issue with that is the pharmacy benefit manager, they negotiate these cheaper prices, but they don't pass on all of the rebate to the third party payer and then onto the customer or the patient. They pocket a lot of this along the way. So they negotiate for lower drug costs, but as a profit point for the pharmacy benefit manager. So moving on to the pharmacy benefit manager, they're responsible for organizing many interactions between health insurers, drug manufacturers, and pharmacies. They really are kind of the intermediate between those entities. They were originally intended to negotiate between manufacturers and pharmacy to lower drug costs for the patient. By doing that, if you want to be on the formulary, you need to lower your drug cost price. And then it was kind of the same thing with pharmacies, where if you would like to be in our network, you were only going to pay so much money for this medication. This, in turn, theoretically should have lowered the cost for the patient or the consumer, but in reality, it's a lot of that is lost between the pharmacy benefit manager and the third party payer. And like I said, that network of pharmacies that is developed. So you must agree to these, like a set of terms where you have to cover all the patients that are in the network. So you can't really, pharmacies don't have the ability to leverage pharmacy benefit managers and say, we're not going to accept a reimbursement from you because we're losing money, because a pharmacy benefit manager does not have to cover the pharmacy in network. So they'll say, you're going to take the reimbursement, or else we're going to pull you from our network and none of our patients will be able to fill at your pharmacy. So there's a lot of issues with that. And then the pharmacy benefit manager networks set the medication reimbursements. Pharmacies do not get to decide how much they charge. So when you are picking your medication up at the pharmacy, and you are billing through a third-party insurance entity, the pharmacy has no control over the cost of that medication. It's completely set by the pharmacy benefit manager and the third-party agreement. So it's outside of the realm of what the pharmacy has control over. Continued here, they develop those drug formularies for insurance companies that are used to determine which drugs they'll cover, like I said earlier. And then they profit by charging more for the negotiated discounted medication reimbursements through the manufacturer to the third party. And then they also charge insurance companies for developing these formularies, so they are a pay for service. And they also charge pharmacies fees for arbitrary performance standards. So they will charge a pharmacy a fee based on the performance standards of patient adherence or the cost of medications that the patients and networks are receiving, things like this. So really the pharmacy benefit manager is pulling money from multiple different parts of this equation. So a little bit of a takeaway to sum things up here. The insurance reimbursement to pharmacies is based on artificially estimated drug pricing from wholesalers, which is that AWP pricing I talked about earlier. Pharmacy benefit managers negotiate discounted medication pricings, but do not pass much, if any, savings on to the insurance companies and consumers. And then pharmacy benefit managers profit off of the manufacturers, the insurance companies, and the pharmacies. So I want to take a step back from the third-party pricing and cost of medications at the pharmacies and talk about discount cards. I'm sure you all have seen the GoodRx commercials and things like that. And I really want to talk about how these affect the pharmacy. They provide discounts by partnering with prescription discount companies who negotiate prices on medications with the help of pharmacy benefit managers. So if you haven't gathered now, the pharmacy benefit managers really have their hands in most of these entities. The way that they work is the way they profit is by charging pharmacies a fee when the cards are used and providing advertising opportunities. So every time that card is used in place of insurance, they'll bill the pharmacy like a $5 fee. And then they market to pharmacies by increasing traffic at the expense of cash paying customer margin loss. And many pharmacies will promote their own discount cards now that give them the best deals to minimize profit loss. So how do pharmacies make money then with everybody's hands in the pot, right? I really like to compare pharmacies to a movie theater or a gas station. Movie theaters are there to provide a service. You pay for a ticket and 95% of that money goes on to whoever produced the movie. The way they make money is by selling popcorn and soda, things like that, candy, or a gas station. The gas station, you stop at the gas station and you're filling your vehicle up with fuel, and then you run in to grab a bottle of water and a bag of chips. They're breaking even on the gasoline, but they made a little bit of money off of the water in the bag of chips. The way that pharmacies now are trying to generate revenue to stay open is a push for clinical services such as vaccines. So pharmacies are able to charge for the service of administering the vaccination as well as have the medication cost covered. So they are actually being paid for the service to administer the vaccine, not only the product itself. They also offer a lot of services such as medication therapy management, which we're able to bill insurance at the front end for the services provided. And these are how we can help meet these metrics that will decrease fees that pharmacy benefit managers charge the pharmacies for their performance. This is where you would sit down with a pharmacist and they would provide counseling to you based on your medication list and give you advice, talk to your doctor, help manage your medications to make sure things are going well for you. And the future holds really for pharmacies, for the corner drugstore pharmacies, it's the expansion of clinical services, such as, potentially prescribing hormonal contraception. There's at least 20 states in the US right now that allow a pharmacist to prescribe hormonal contraception without seeing a primary care physician. So it can be done right there. This is really how the pharmacies are going to continue to expand. So how do you save money? I know that's really the important part of this, right? When choosing a pharmacy, it's important to make sure you're choosing an in-network pharmacy that's covered by your third-party plan. They will offer you the best copays. They generally offer a discount if you decide to fill 3 months versus 1 month. Generally, mail order through your insurance plan is going to be the cheapest. If it is offered, you will generally find that you cannot beat the price of mail order if you can put up with the service of mail order. Take advantage of manufacturer assistance plans if able for branded medications. So if you are taking a name brand medication, chances are there is going to be a manufacturer assistance program that allows for the medication to be covered for free if you meet their requirements, regardless of insurance coverage or not. And then meet with your doctors and pharmacists to really make sure that the medications you are taking are effective and meaningful. You can cut costs by optimizing your therapy, your medications, and making sure that you're not taking unnecessary products, making sure that you're taking products that are cheapest in the class, or maybe even combining products so you're only paying one copay instead of two. These are services that are offered virtually at any pharmacy through your insurance plan. And they really are. They're very good at cutting costs to the patients. And with that, I'll turn it back over to Eileen so she can open up the floor for questions. I just have this screen up if people had questions about the layout here. It's quite busy.
We did have a question come in right away, which asks about whether or not generics are created equal in terms of their chemical structure, their quality, their effectiveness, and side effects.
Greg, do you want to handle that one, or would you like me to?
Why don't you take it, Tom?
Okay. So generics are, from an FDA standpoint, you have to prove that it is equal to the brand name medication to receive generic approval as like for a substitution. Now there are generic medications that carry the same active ingredient that do not have that FDA approval and do not meet generic equivalents for the brand name. So in terms of brand versus generic, it is an approval process to make sure that they are considered equal. Yet not all generics meet that threshold, if that makes sense.
Does that allow them to come on the market then? One that does not have the same chemical structure?
So I'll give you an example of a medication that's it's called Concerta. The active ingredient in it is methylphenidate. So there are certain manufacturers of the generic product that you can substitute a Concerta prescription for. So you can substitute methylphenidate for Concerta for certain manufacturers, but not other ones. To fill the other prescriptions, the other generics that don't meet that level of equivalency, you'd have to receive a prescription for methylphenidate, if that makes sense. It's a little.
We've seen that where you have the brand name on the prescription versus the generic, correct?
Yes.
Okay.
And that's a legal requirement.
Okay.
So by and large, they're going to be chemically equivalent. It's just that there are some categories where there's multiple products, and substitution, as Tom was saying, are in kind of a triangle.
Okay, our next question, we have a few more. Who can regulate the cost increase on drugs, since the taxpayers are really funding the research? And the concern here is with soon the Moderna vaccination will not be covered, I think. That's part of the concern of this question. The cost goes for for-profit corporations. So this individual says the answer is still Medicare for all instead of defunding of Medicare that's happening now. So the question is, who can regulate the cost increase on drugs?
Well, I think there's, when we think about those 5 rules that are broken, in a market economy. And those are like, if you talk to any economists about a market economy, those 5 rules are going to be the rules that they all agree kind of govern a successful market economy. So I think we kind of have 2 paths we can go down. Let me take the path that most other developed countries have gone, and most other developed countries that have that are paying half the cost that we are for prescription drugs. These are, for the most part, countries that do have single payer systems of some type. So you either have a single payer insurance company, or the country actually runs the healthcare system. And so that puts one organization in the position to negotiate all the drug prices. And so from that standpoint, I think if we took the handcuffs completely off of Medicare in the United States, then that would allow them to do that negotiation, and then across all drug sectors that they administer, and then that would trickle down to the private sector. A lot of people complain about Medicare being less efficient than the private sector, but the reality is almost anything Medicare has done in terms of pricing, the private sector has jumped on pretty quickly.
Follow
Okay.
right along.
So the other path, so that's one path, which means we would go to a single payer system like the person is suggesting, Medicare for all. The other path I believe we would have to go through is we really have to put the consumer in the position to make more of the choice about the medication. Because the problem that exists with those 5 broken rules is that the person who pays for the drug is different than the person who makes the decision about the drug, and that's different than the person who consumes the drug. And there's no other commodity in the marketplace in the United States for that exists. And so the way that we could bring those circles together would be, rather than, let's say, the physician giving you a prescription, the physician gives a diagnostic code to the pharmacy. So I have high blood pressure and I have high cholesterol. So they would just send that to the pharmacy and say, Greg has a diagnosis of high cholesterol. I go to the pharmacy and I talk to them, and we get together and we select the most economic choice for me that has the best therapeutic outcome. And now we start to have the decision making being the person who's administering their money being the same person that's consuming the drug. And if we can get those closer together, now those are 2 dramatically different approaches, but they're different kind of pathways that we could go to.
Another question we have is, do you see any strategies to reduce the power of the pharmaceutical lobby?
No. I mean, people that have tried to basically have not had any success because they have freedom of speech rights. They have the ability, I mean, like really PAC spending, political action committee spending. No one's really been successful at that. I think the best way we can impact that lobbying is really organizations like yours. That, I always tell people, if on election day every person in the United States went to the polls and voted, we would see a true revolution in this country, in democracy. But that's not what happens, and that's what allows lobbies to control, is because we really have these private sector able to wield power and not be responsible to the voters.
And that leads to another question that we had come in about patents. Who determines the patent? Is that the FDA controlling that, or is that also impacted by the lobbyists?
It's determined by law. So patent rights in the United States are determined by law. So it's 20 years. If you invent something, you get a patent for 20 years. But that is subject to legislative changes that have occurred. So they get an extension. So Congress actually gives drug companies, if a drug is in, let's say you get 20-year patent, and if it's 10 years in clinical studies, then you get half of that time back. So you get 5 added onto your 20. So you're gonna get 25. And so, you see these patents, and then there'll be a bunch of lawsuits that'll be filed, and those things will extend. So the problem isn't necessarily the original patent law. The The problem is the abuses, the legal abuses that continue to extend and extend and extend those patents.
Okay, thank you for that. I thought there were some different
Yeah,
years.
and I think
for
I think I
different-
saw a quick question related to that, and it's like, would patent, does a drug coming off patent affect pricing? And I would say, when I was a pharmacist in the 80s, you would see a crash of the price after the drugs came off patent. And as time's gone on, nowadays, drug comes off patent, you don't see much of a price change that occurs. You basically, I think there's sort of a passive agreement between drug companies to say, let's just all kind of go to the well of this high price and let our marketing fight for market share. And generally, you have to get to I think your fourth, fifth, or sixth generic before you're really going to start to see that price crash occur.
And Tom, you covered the information on the pharmacy benefit managers. We have a question asking, who are the major pharmacy benefit managers? It seems like they have a lot of power.
Caremark, CVS Caremark, Optum, and Express Scripts are your top three.
So they are
they
owned by pharmaceutical companies. Who do they work for?
I'd have to look at the details. If you start to look into pharmacy benefit managers, you'll notice that things are not exactly clear. There's intent with that to keep things kind of muddled. So I know that like Optum RX, there's an insurance company and a mail order company. There's multiple entities of the same there's multiple different entities owned under the same company. Like CVS Caremark is the mail order company, the drugstores, and then the pharmacy benefit manager. That's how you're gaining market control in those situations, is by having this different entities in this system owned by the same company.
Okay. And how does advertising impact drug costs?
How does advertising impact drug costs? In what capacity, I suppose?
Well, we see a lot of commercials on, for certain medications. Some are advertised a lot more than others. So just wondering that this is just one of the questions that we had come in. How does advertising impact the cost of drugs?
You'll see a lot of new brand name medications come to market, and these companies that own the patent for this medication, there's only one company making this product. So they advertise these products on the TV, on the radio, whatever. And then also go into doctors' offices and chat with providers. And you'll see a shift towards, like, for example, Mounjaro, as the product that's a new diabetes medication that's hit the market recently. There's a lot of advertising going on for that. Really is where I see the advertising affecting the medication, is in swaying providers to prescribe that medication, that expensive brand name medication, more.
And you've addressed a lot of issues regarding drug costs. Does this apply also to biologics?
Biologics fall under a very specific entity. That's a little bit more complex. Greg, do you know any of the details behind the biologic pricing?
And what are we talking about when we're saying biologics?
So that would be a product like Humira. It'd be a high cost, complex. It's a certain class of medication. It's very specific.
Yeah, they're more complex. We call them biologics. They're more complex molecules that interact with specific portions of the physiology of the system, as opposed to like when you take something for GERD and it's just shutting down the acid production. So biologics, I mean, by their nature, they've always been more expensive, because you can charge more for a biologic because it's perceived to be a more complex molecule to produce and put to the marketplace. So it commands a higher tier of pricing.
A lot of biologics are done through specialty pharmacy, which is done directly through manufacturer or through a separate entity that deals with these high cost drugs, which I am not personally too familiar with. You'll see biologics coming off of patents like Humira is just about to hit. That's one of the largest biologics on the market. It's about to hit. It's about to hit the biosimilar stage, which is essentially like a generic stage, and that will affect the shift of the cost dramatically because it's one of the largest biologics on the market. But mainly those are dealt outside of the realm of the drugstore pharmacy that I'm familiar with.
Another question is there a list available for the drugs to be negotiated each year by Medicare?
Oh, yes. That's public knowledge. The formularies. If you search your if you search your plan, depending on the like priority health Medicare or something like that, you can find the drugs that are covered and the tiers that they're covered in on the internet in a PDF form.
Okay.
So the drugs, I mean, they're only allowed to negotiate 10 drugs in the first year, and they will, they're scanning through the most expensive drugs that they have, and then they're going to go they're going to go to that list. I'm trying. There was an article published in the Journal of American Medical Association that discusses this, but it's behind their firewall. So I'm trying to get that list and then see if I can't pop it into the chat. So it gives what they think are the biggest candidates based on expenditures by the Center for Medicare and Medicaid Services.
So that's what they're doing. They're picking the list according to how much it's costing Medicare to pay for those each year.
The law requires that.
Oh,
the law
okay.
requires them to look at the most expensive drugs and keep adding to those. And then in the first years of implementation, it'll be Part D. And then in a few years after implementation, it'll include they're allowed to add Part B. So it's like 10 the first year, 15, then it can be added the next year. And then I think you can add Part B's the third year. So there's like a whole very regimented, I'm trying to see right now if I can't find a way to put this list of candidates that they think it's gonna be.
We also have a question regarding traditional Medicare versus Medicare Advantage. Is there an impact with the transition to ACO REACH, which takes effect in 2023? Do you have any information on that?
I do not.
I do not either.
Okay, another question on pharmacy benefit managers. Are they owned by stock market groups that buy out businesses to purposely take out the profit?
I see that, yeah, and do they hide behind multiple names? They do hide behind multiple names. Generally, you'll see that these pharmacy benefit managers are owned by entities that are involved in the reimbursement system. For example, Optum is owned by United Health Group. And then CVS Caremark is part of the CVS entity. So you'll see them pairing with other parts of the same reimbursement system to kind of cut out the middleman, so to speak.
Okay. Let's see, I think we're covered most of our questions.
So I popped something in the chat that has some list of drugs from Part B and Part D. You can ignore those numbers because I just cut and paste from a table, so it included some expenditure. So just ignore those numbers that are after the drug names. But it has what at least some people are thinking are going to be the top Part B candidates and the top Part B candidates.
I think we might have lost Eileen.
Oh, I think I'm back.
There you go. Okay.
Okay, great. Well, I think those are all of our questions so far. I want to thank both of our speakers, both Professor Greg Wellman and Tom Burns, for a very, very informative program. And want to thank our audience for joining us this evening and for all these thoughtful and sometimes complicated questions.
Great questions.
Yeah, great questions. So, okay, I'll turn it back over to Robin.
All right. Well, thank you, Greg and Tom. That was
Okay.
really so interesting. And it really did help, help sort it out a little bit. It just seems so arbitrary, but this kind of puts pieces in place. So thank you for sharing your expertise with us. We really appreciate it.
Happy
Thank
to be
you.
here.
All
Thank
right.
you for
All right.
the invite.
We're going to
All
go
right.
ahead